Hello, everyone. Welcome back to Luncheon with the Experts, a Carcinoid Cancer Foundation program brought to you by Ipsen Biopharmaceuticals. My name is Rain Bennett. I am your host every week here with you, hosting the show, having a good time, and learning a lot about neuroendocrine tumors. If you aren't familiar with me, I'm a filmmaker and writer. I've been working with CCF for 10 years to produce video content like this, live video series, as well as produced videos, treatment-based videos, patient-centric videos, all with the same mission in mind, and that is to raise awareness and educate people about this disease. So if you are a regular to the show, you are probably already saying hello and telling us where you're from: Wisconsin, Canada, SoCal. What's up, SoCal? I bet it's nice out there right now. But if you're new to the show, I want to say welcome. We're here every week, and the real value I see from the show is twofold. You're going to get a lot of great information from leading experts in the field, but also we've cultivated quite a community here, and the net community in general is very, very strong, very, very supportive, and very, very helpful. So introduce yourself to people. Let them know it's your first time. If it is, we have Poland in the house already. See, I love seeing how far this program reaches. So introduce yourself, tell us where you're signing on from, and the community will embrace you. I promise you that. Before we get started, we always want to thank our sponsor, Ipsen Biopharmaceuticals. Without their support, we wouldn't be able to do the show. And we always have this disclaimer from them, and that is that the opinions expressed by our guest, as well as the questions asked by you all, the audience, haven't been created or suggested by the Luncheon with the Experts sponsors. And CCF doesn't endorse or promote any of the views, opinions, or information provided in the presentation. Audience members should not rely solely on the opinions or information expressed by the guests and should seek guidance and direction from their own medical advisors regarding any choices they make about their health or treatments. All right, a lot of words there. The main takeaway is that final line. We're going to give you some great answers to your questions, some good general advice, but by no means do we know your specific case, nor does our guest. Most likely, might be your doctor. So take that general advice, take those answers to your question back to your home team, which does, and make the best plan and path moving forward for you. If you've been a part of this journey for a while, you know that each case of this disease is unique, and therefore each plan and path moving forward is as well. Today, our guest is Dr. Thomas Hope, who I've spent some time with before. We were chatting before we started the show today that he was a part of kind of the first iteration of our Facebook Live programming, and we were doing it in person then. I was out in San Francisco with him, and we talked about how efficient things have become now that we are all on Zoom. Dr. Hope, how are you? Welcome back.
Happy to be here. Excited to have a conversation today.
Absolutely. So for those that may not be familiar with you and the work that you do, tell us a little bit about yourself, where you work, what you do, your role in the net community.
I am a radiologist and nuclear medicine physician. I work at the University of California, San Francisco. I've been involved in imaging and treating neuroendocrine tumor patients for about 6 or 7 years. We have quite a well-developed neuroendocrine tumor program here, led by Dr. Bergsland, who really got me involved in the neuroendocrine tumor community. And I've been involved in multiple trials, also involved in the North American Neuroendocrine Tumor Society, NANETS, on their board, and just generally engaged and interested. And I love this community that the neuroendocrine tumor patients have created, and it's been a wonderful experience to be a part of it.
Absolutely, and a plus one to the loving the community. It's a strong community, and I love that, and I love to be kind of a part of it as well. So I appreciate everybody that has embraced me. So, folks, Dr. Hope gave you a little bit of background where he really spends his time. Now, he has told me that no questions are out of bounds, and he is prepared to field them all. But I know you all have a lot of questions about imaging. It comes up every week, and so I think you're going to get a lot of benefit from that, a lot of value from that. The main value is being able to get the questions across. This virtual interactive one-on-one session. Okay, the video will live. It'll be evergreen on the Facebook page, and starting Monday, we'll republish it to YouTube for those who don't have Facebook. So you can always watch the replay and get a lot of value for sure. A lot of information in there, but the real value is getting a question across that you may have been struggling with, or your team may have been struggling with. So if you know someone else that should be here right now, let them know the show is going on. Remind them if they're usually here. You can tag them in the comments. You can share the video of their wall, call them, text them, fax them, whatever you need to do to try to help them out. Because I think, being here is really, really the most benefit. Caregivers, support group leaders, Any and all are welcome. And another thing I like to ask you all to do, you do a great job every week. If you see a question in the sidebar that you also have, or you're also interested in the answer to, right under the comment, there's a couple of options, like and reply. If you hover over the like button, it gives you a couple of other emotions to use. They all work the same way for me. It effectively upvotes that question. If I see that 7 people have liked that question, I know there's a high demand for it. And while I'm going through the questions, which inevitably we can't get to them all, I'll know that one is really in demand, and it's going to make, I'll make sure to get it across. So that just helps me do my job better, which of course is to help you. So go ahead and start sending in your questions. And Dr. Hope will field them, and we're going to give you some good answers. Dr. Hope, tell me a little bit about, you said about 6 or 7 years, right?
Mm-hmm.
Tell me a little bit about the progress you have seen, and we'll stick with imaging in terms of imaging in that span.
Well, part of the progress is me learning, as well as the progress of the field at the same time. My first salvo into neuroendocrine tumors was running the Gallium-68 DOTATOC program. So this was before the approval of NetSpot or Gallium-68 dotatate. There was no somatostatin receptor PET available in the region, and so we put together a program to make Gallium-68 DOTATOC available to patients, and that's how I got into neuroendocrine tumors initially. And so it was obviously learning about molecular imaging, how it's used. We started using a lot of PET MRI and how you combine both MR and PET together to stage patients. So understanding the role of liver MR, particularly hepatobiliary phase MR for people who have liver dominant disease.
Mm-hmm.
And then a lot about, I think the thing that's we all struggle with neuroendocrine tumor is the pace of disease. And what I mean by that is NET is a relative, and this is a general statement, but not true for everyone, is a relatively slow-paced disease. And so in radiology, we're used to just saying, hey, it grew or didn't grow compared to the past study. But that's oftentimes actually not helpful because nothing's ever grown compared to 3 or 6 months ago. But you need to look back and watch over time. You need very consistent imaging methods to actually tell if there's been progression or change in the disease over time. And so it's really thinking about patient-specific imaging, how to do it properly every time, and then really taking into account the trajectory of that patient over time.
Got it. And what are some of the other, what are the areas for potential improvement that you would like to see in terms of imaging?
Yeah. So I think in general, our imaging methods that we have work pretty well. Right? Like it's not like we're missing things. With dotatate PET, we see our disease maybe better than we need to, right? So seeing small 2 millimeter nodes doesn't really make a big difference, but we can now see them with dotatate PET. So we have a technique that's sensitive enough to see what we need to see. I think it's more in the implementation and understanding when to use what. What I mean by that is, if you have bone dominant disease, getting a CT chest, abdomen, and pelvis, probably not going to help you that much because you can't see bone disease well in that. If you have liver-only disease, you want to be very consistent in the type of imaging you're using over time so that you can track the disease, the pace of the disease, et cetera. So I don't think I see a lot of advantages in newer imaging techniques. It's availability of it and using it properly in the right patients, which happens to be a lot about physician education, patient education. And we've done a lot of that, writing appropriate use criteria, giving lectures to physicians to really highlight this. And, in the last 5 years, we've gone from pretty much no one using hepatobiliary phase MRI to that now being the standard imaging modality for most patients with liver dominant neuroendocrine tumors. So it's sort of fun to see, these ideas that you've come up with years ago now become sort of boring. No one even thinks that it's important anymore. But really, I think that's the main. And then there's insurance reimbursement issues trying to address that. But, I think we have very good tools on hand for what we need right now to determine how to manage patients from the imaging perspective.
It's good to hear. So we have a question, about Gallium-68 dotatate. So Stephen says, what is the Gallium-68 dotatate uptake times margin for error? I noticed that the technician seems to be in a hurry, and my uptake or wait time is typically 30 minutes plus time to set up on the PET scanner. Does the operator know when there is insufficient uptake? And a few other people are interested in this answer as well.
That's a great question. So in general, dotatate gets taken up very quickly, like within 5 to 10 minutes. So you can actually image patients very early. Now, standardly, we image patients at 60 minutes because that's what FDG PET has done, which is sort our most common imaging modalities. So it just keeps the same workflow. So most imaging centers keep everyone on sort of the same pace, because it's much harder to have some radio tracers be at different delays than other radio tracers. So most sites will use a 60-minute uptake time, but it does not matter if you're at 45 minutes or 90 minutes, really. That won't affect the diagnostic quality of the study. Now, separately is this idea of uptake. You can measure uptake, right, with the standardized uptake value, the SUV. And the SUV is probably impacted a little bit based on the time of uptake. So, there's going to be some variability in that. It's not going to, again, change how well you can see a lesion, but maybe it'll change the uptake in the lesion by 5 or 10% or something like that if you have a significantly delayed or shorter uptake time.
Got it. Hey, thanks, Stephen. And if you have a follow-up question, let us know. But hopefully that helped. I know a lot of people are interested in that. Next question from Sarah and a few other folks. What is good for detecting bone mets?
Yeah, so bone mets, that's where somatostatin receptor PET, DOTATOC, DOTATATE, that's going to be the best imaging modality for patients who have bone dominant disease. Now, the issue with people who have bone dominant disease is you don't really want to get you can't really get a DOTATATE PET every 3 months, right? So it's sometimes hard to track people over time who have bone dominant disease. So you'll use sort of these, you'll use a somatostatin receptor PET every year, or depending on the pace of the disease, to check in and see where you're at. Sometimes you can use, if you have pain or symptoms, you want to use an MRI to take a closer look at a small region. It's very hard to track the whole body with MRI, but you can track regions like a lumbar spine, back pain, hip pain, things like that with an MRI. CT is very difficult to track for bone disease, and particularly you'll get a lot of reads of like there's been progression in the bones, and that patient's actually responding, because responding bone lesions will become sclerotic and dense on the CT, so they'll become more apparent even though they're actually responding. So the bone dominant patients can be a little bit hard to track, but DOTATATE PET is going to be your best way to check in and see where your overall disease is at the time.
Got it. Thanks for that answer, and thanks for your question, Sarah. Similar question from Tina. What's the best to detect nets in the colon?
In the colon, that's an interesting question. So to look for primary tumors, right, in the colon, that would probably be mostly done by endoscopy, right? Doing a colonoscopy. You can biopsy the tissue, right, so that you can actually go get a histological diagnosis of the cancer. You get a Ki-67 and everything. So you can go all the way up to the terminal ileum with endoscopy to see where it's at. Now, there are techniques that we don't use as much as before, CT enterography. There are these methods where you drink a bunch of fluids. I'm sure many people on this webcast have had these exams. You drink a liter or more of volumen or whatever it might be, and then you do a CT scan soon after, so your bowel's dilated so you can actually see the primary tumor. There hasn't been really a good head-to-head of this, but in all honesty, DOTATATE PET's going to be better for seeing that than a CT enterography, although at some point in time, those studies are useful because they can be helpful to determine if there's obstruction or physiologic issues with your bowel, adhesions, things like that, because the fluid won't get past the area that's obstructed. So there's some additional information you'll get from it that you don't get from a DOTATATE PET. So in terms of the initial staging, a DOTATATE PET is probably the best imaging modality to determine if there's an unknown primary. So many patients will come in maybe with symptoms or something where they're worried about having a neuroendocrine tumor. And when we wrote the appropriate use criteria for somatostatin receptor PET, we actually all agreed upon using DOTATATE PET in that setting. It's actually not common to find an unknown primary using somatostatin receptor PET, interestingly enough, but the reason we all agreed that that's the best study is to prevent patients from getting 6 different studies and then getting a DOTATATE PET. You might as well just go with a DOTATATE PET, answer the question. If you don't see it there, you're not going to see it on an MR or CT or other methods.
Got it. Hey, thanks, Tina. Folks, if you just joined us or joined us a little bit late, this is Luncheon with the Experts, the Carcinoid Cancer Foundation program. We're here today with Dr. Thomas Hope from the University of California, San Francisco, who also works with Dr. Emily Bergslund, who's been on the show and a friend of the foundation. And we're talking about a lot of things, but we've been talking primarily so far about imaging. So welcome to the show. If you joined us a little bit late, go ahead and send in your questions. We're going to keep moving forward. Pivoting a little bit still, Belinda says, how effective is PRRT if the cancer is metastasized to most organs in the bone?
How effective is PRRT? So The straight up answer is every patient's different, right? So in some patients it works wonderfully well, in other patients it doesn't really work at all. So, we can only speak about averages, right? We run clinical trials and we look at the average response time to, progression, et cetera, across a population of patients. It obviously depends a lot on the individual patient when you should use PRT and how that efficacy compares to other therapies. I generally think if surgery is possible to debulk, that should be done first, right? Because it sort of sets back the clock, and you can't, oftentimes surgery is not an option later on. Now, in the setting you described where you have extensive disease in multiple organs, bones, et cetera, surgery is not an option. Probably liver-directed therapy is not an option. So now you're talking about systemic therapies, right? And then it comes down to, in the systemic therapy world, you think about where your primary tumor is. So the NETTER-1 trial, which I'm sure has been discussed a million times on this webcast, was done in small bowel nets, and it compared to double-dose sandostatin. And PRT greatly outperformed double-dose sandostatin in time to progression. What that means is if you treat a patient, you image them over time after treatment, and you wait to see when the imaging shows the disease progressed. With PRRT, it took a very long time for the disease to progress, okay? So it's really a benefit in progression-free survival is the term we use. Now, the interesting thing is that actually a patient's disease doesn't shrink that much. And in NETTER-1 trial, something like 13 or 15% of patients actually had their disease shrink after treatment, which is sort of surprisingly low given how much benefit there is in progression-free survival, where people take probably 25 to 30 months for their disease to start to grow again. And I don't think we actually understand how that works. Why is there such a prolonged progression-free survival in small bowel nets? Now, when you look at the other therapies available to small bowel nets, we're talking about mainly everolimus. And it's pretty clear that PRRT is superior to everolimus and has a greater efficacy in preventing the growth of tumor than everolimus. And that's actually when we wrote the appropriate use criteria for PRRT, the reason why that's the one setting where we made it clear that PRRT should be used first line after progression on somatostatin analogs in front of everolimus. Even though there is no head-to-head to everolimus, the existing phase 3 trials really suggest that PRRT is a better drug. Pancreas is a little different of a story. Pancreas is also very effective in pancreas. It's obviously on label in for pancreatic neuroendocrine tumors. The FDA approved it in PNET. In PNET, more patients actually have their tumors shrink. So probably something like 25 or 30% of patients have their tumors shrink when treated with lutetium-177 dotatate PRRT. But you don't have as long of a benefit in terms of progression-free survival. So you have more shrinkage, and also it comes back faster. And that's probably because PNETs are slightly more aggressive. More aggressive cancers are more likely to be radiosensitive, hence the higher shrinkage rate, but they're also more likely to come back faster as well. So PNET's a slightly different, and we don't really have a good prospective phase 3 trial that's been reported out in pancreatic neuroendocrine tumors. And I think that's something that's really lacking. Now, the difference in pancreas is not, and PRRT is clearly an effective therapy in pancreas. And I think most patients if your primary tumor were a pancreas tumor with that description, would receive PRRT at some point in time. The question in pancreas comes down to CAPTEM. CAPTEM, capecitabine temozolomide, is an oral chemotherapy regimen, which is actually also very effective in pancreatic neuroendocrine tumors. It's unclear whether or not PRRT or CAPTEM is more efficacious and where one should use it. Some of the things, and this is more of an art form, and this is really, I learned a lot of this with Dr. Bergslin at Tumor Board. We go around like, which one should we use in this patient first? And there's no right answer. But the things we sort of think about are bulk. If a patient has bulkier disease, we might actually start with CAPTEM to debulk the disease, maybe shrink it down a little bit before you start PRRT. The onset's faster with CAPTEM, right? You take a pill and you immediately have therapeutic dose, whereas with PRRT, you have to do 4 cycles every 8 weeks. It might take a little longer to get the dose in there. If you have really high uptake on dotatate PET, SUVs, 50, 75, 100, over 100, maybe that would suggest that PRRT would be a better option than CAPTEM. So you have to take into account all these different factors to determine which one would be a better therapeutic option. But PRRT is effective in PNET as well. It's just less clear where it should be placed in the order or the sequencing of therapies in PNET. Now, I totally did not directly answer that question, so ask another question to follow up to revise exactly what you want me to say.
Yeah, but that was so thorough. Like that probably answered, 20 more questions they had. I appreciate that, Belinda. But I definitely plus one to what Dr. Hope says. If you have any follow-up questions and you're still on the show, let us know. But I appreciate you asking. Next question from Jeff, longtime viewer, first time questioner. Jeff, I'm glad you're speaking up. For intra-arterial administration of PRRT, what volume of liver dominant disease would prove most amenable to treatment?
That is a great question. So liver IA PRRT, there's a lot of debate in this space as to whether or not that's the right way to go. There was literature out of the University of Heidelberg in sort of the late 2000s. I think it was published maybe 2011, which showed a really marked increase in uptake in liver disease when Gallium-68 DOTATOC was administered intra-arterially compared to intravenously administered Gallium-68 DOTATOC. Okay, so an imaging agent. They showed maybe a 4-fold increase, 3-fold increase on average across patients. And that actually got me very excited. We ran a phase 1 trial doing IA PRRT here at UCSF with yttrium-90 DOTATOC. So this was, lutetium wasn't yet approved. And so we were doing with yttrium-90. We labeled it in-house. And we actually didn't recapitulate that. So what we did is we actually gave Gallium-68 DOTATOC intravenously. And then we gave it along with the intra-arterial therapy. We did see some patients who had an increase in uptake, but not nearly as much as you would have expected. And what we believe is going on is that when you give Gallium-68 DOTATOC, you're giving a small mass dose. So if you think about the number of particles, right, the number of DOTATOC or dotatate molecules that are floating through the blood, you give maybe 20 to 40-fold fewer, maybe even 100-fold fewer when you're giving an imaging dose compared to a therapeutic dose. So when you give a therapeutic dose, the amount of molecules is much higher. And so you're going to saturate the receptors more easily with a therapeutic dose, sort of tempering the benefit of giving it intra-arterially. Now, what that means is two things. The higher your uptake and the larger your volume of the disease in the liver, the more beneficial intra-arterial is going to be, because the more receptors there are on the tumors that are being treated. Okay, so the more disease that's very hot, the more benefit, more bang for the buck you're going to get for an intra-arterial administration. Now, I will say there's no negative of giving it intra-arterially other than the risk of the puncture in your groin, right? You have to give a catheter and put a catheter through your femoral artery to get up to your liver. There's risk with the femoral artery puncture, but outside of that risk, it doesn't hurt. It's not like giving the drug intra-arterially is going to make it, it will never be worse than giving it intravenously, right? Because in essence, if it just flows through the liver, it just goes to the venous pool and just redistributes like an intravenously administered drug. So I think there's still questions as to whether or not there's significant benefit with intra-arterial administration and how important that is clinically for a patient. The annoying thing to a certain extent is that it's very hard to get reimbursed for intra-arterial administration of lutetium dotatate because the package insert lists that it should be administered intravenously. And so if it's given intra-arterially, some insurance companies, particularly one important one is Medicare, will not reimburse you for an intra-arterially administered dose of lutetium dotatate. Okay, so it's not something you can just do easily. There is a trial, which I'm very much so looking forward to, that, wow, I'm blanking here. Lisa Baudet at Memorial Sloan Kettering is running. She has an intra-arterial lutetium dotatate trial that is partially sponsored by Novartis. They're providing the dose, right? Because there's that insurance issue. And she seems to be seeing good results, although we haven't seen anything published yet to date. But I think more needs to be done to really understand when to use it and which patients will benefit most from it. But that's my quick thoughts on intra-arterial PRRT.
Awesome. Thanks so much. Thanks. And thanks again, Jeff, for your question. Next question from Karen and a few other people. Are there any drugs or supplements that we should stop taking before getting the gallium scan?
That's a great question. So, for a long time, we talked about holding long-acting somatostatin analogs before you get a somatostatin receptor PET, right? The idea was these somatostatin analogs competed with the dotatate or DOTATOC for the somatostatin receptor and would diminish our ability to see lesions. What's been interesting is there's now been studies doing multiple at 2 time point somatostatin receptor PETs before and after people start long-acting somatostatin analogs, and we have not seen attenuation, decreased uptake associated with the concurrent administration of somatostatin analogs. If anything, it's better, which is sort of surprising. So historically, I've always said patients need to be at least 3 weeks out from their last dose before getting a somatostatin receptor PET. Okay, so that's like our historical story. But I think I'm becoming much more lenient towards that, and I'm fine with people a week to 2 weeks after, particularly with lanreotide. Lanreotide has a longer intravascular half-life, and so it's a flatter plateau. So it's not like you get peaks of the analog in the blood pool after the intramuscular administration. So that's becoming much more lenient, and the same is going with PRRT. I'm much less worried about the timing of long-acting somatostatin analog therapies when it comes to the timing of PRRT as well. With short-acting, 24 hours, you should just not get it within 24 hours before your imaging study. I think some people recommend up to 48 hours as well, but 24s, I'm fine with that as well. Other than that, there's not really a lot of things that would impact the uptake on a dotatate PET, so you should not worry about that. I would say I have seen one patient who's had sort of attenuation of uptake due to very high dose SSAs, getting 120 milligrams Q2 weeks of sandostatin because of symptom control. So that it is possible, but it's very rare. And of the thousands of these studies I've read, I've seen it once. So in a general statement, don't worry about it. Now you're going to go to your imaging center and tell them Tom Hope said this, and they're going to tell you our protocol is something different. So just be aware of the fact, whether my opinion is something, that doesn't mean that your site will have that opinion. So just make sure that you mention it well ahead of time, so that people, if that issue comes up, it doesn't cause a kerfuffle.
Fair point. I have a question from Katerina, maybe too case specific, but we'll see. Maybe we can still give some general advice. Katerina says, I'm 6 months after debulking surgery and peritoneum and lymph nodes, open surgery in my abdomen, and now one hospital sees new low lighten spots. Could it be too early after surgery? They recommend PRRT now, and the Ki-67 is less than 1%.
Okay, so new, I'm assuming these are like hypodensities on a CT that are new, et cetera. I don't know the imaging and I can't speak to it directly, obviously. Right. So there are many things you want to think about. So one, presumably this is on a CT scan. CT scan is not the best thing to see liver disease. And so, if we're worried about the liver, maybe getting an MR could be helpful. And the other thing, obviously, is a somatostatin receptor PET. If PRRT is being considered, a somatostatin receptor PET should obviously be considered prior to using PRRT for treatment. So if that's, if that's the path you're going down, I think that's important. Now, I think an important thing for people to remember is we're not in a rush to give PRRT. If you have a Ki-67, well-diff G1, 1%, you're going to have neuroendocrine tumor for years to decades, right? So we're not at a moment where we're, oh my goodness, there's one small little lesion, let's give PRRT. No. Okay, so pause, take a step back. You want to think about sequencing, pace, how long your expected life is going to be. You don't want to just give PRRT at the first sight of anything. And particularly, I do find that a lot of sites use PRRT any moment they see anything. And my style is a little different, and I don't know if it's right or wrong. I obviously believe it to be right. But in low volume disease patients, I oftentimes don't use PRRT upfront. PRRT does not cure cancer. It will not make it go away permanently. So in essence, you're using a bullet at a time when it might be less effective than it could be later on in the course of your disease. So it's really important to get input from nuclear medicine physicians such as me about when to use PRRT, surgeons about whether or not that one could be done. Should they go back in and ablate it? An interventional radiologist, maybe the liver-directed therapy is good, and obviously, most importantly, a medical oncologist, right? Because there are systemic therapies that would be considered as well. And sometimes in low-volume patients, that's when actually it's a good opportunity to use something like everolimus, right? Generally, it's less effective than PRRT, obviously. But when you have very low volume disease, it's a great opportunity to use it to see if there are patients who do benefit from it. And you don't want to wait till you have high volume disease to use a drug like that. The other thing that when you have low volume disease to think about is somatostatin analogs. A lot of times at our institution, and Dr. Bergsland has taught me, in essence, everything I know, obviously. But one of her styles is in low volume, slow growing patients to use SSAs and maybe doubling the dose of an SSA to see if that works in slowing the progression of disease. It gives you an opportunity to see the pace of disease, how fast it's growing. And it also pushes out PRRT potentially 2-3 years, which is great because that means you're pushing out potential toxicities of PRRT by 2 or 3 years. And, you know, nothing comes without a cost. And PRRT has a cost. If we could give PRRT endlessly to people without any toxicities, then yes, I would take PRRT upfront in the very beginning. But you can injure your bone marrow, you can cause injury to kidneys and liver, and you can't get endless cycles of the drug. So using it at the most opportune times when it has the most benefit is really important. So I don't know, obviously, the specifics of that case, but that's my general approach to patients with low volume disease.
You know, I've never, it makes a lot of sense. I've never heard it put that way, or at least that simply. And I like that response a lot. You know, you had mentioned during that answer, it's not going to, I don't know if you said it's not going to cure the cancer in those words, but you know, essentially.
I said that specifically, yes.
Okay, all right.
I use the C word, but with the negative.
Yeah, right. So I have a question, you know, this kind of prompts me to ask this question. It's a big question, but a lot of people have it, and I sense frustration and understandably in it. Bernadette simply asks, is it possible to be cancer-free?
So, I mean, everything's possible, right? So obviously I'll never say, no, it's not possible to be cancer-free, but in general, nearly everyone with neuroendocrine tumor recurs, right? It comes back, and we generally don't believe neuroendocrine tumor is a curable disease, i.e. we cut it out and it goes away. Now, there are people, there's certainly appendiceal carcinoids are known to be very well behaved. If you get it early enough and cut it out, potentially those patients can have no recurrence. But as a general rule of thumb, once you have node positivity or definitely a MET, there is no cure of that disease. Now, the way I think about neuroendocrine tumors, I think I'm going to get a little bit off target here, but I get frustrated with fundraisers, the media, and we talk about cancer being a battle and you winning the battle and you curing it. And the people who get cured, particularly breast cancer, is one of these cancers which is framed in this way that, you know, there are winners and losers, and you as a patient should be a winner. Right. Wow. And I find that very frustrating because, you know, there is no cure to cancer. You define your cancer by how you handle it, by your choices, and there's no right or wrong decision about what cancer therapies to get, et cetera. And I think it's really important that we change that tone about how we think about cancer. It's not about cure. And for me, my goal as a physician is not to cure cancer. Everyone says, you know, there's even cancer centers in this country who, you know, I think they have a line through the word cancer because the goal of the cancer center is to cure cancer. I am not thinking, at least in my lifetime, we're curing cancer. I do believe that we can make cancer a chronic disease. I want cancer to be hypertension, right? Mm-hmm. I want us to convert cancer to a chronic disease that we put under control so patients can focus on quality of life and what matters to them, rather than worrying so much about curing. We put so much attention on the word cure. I don't think that's not my goal, and I don't think that should be my patient's goal. My patient's goal should be, how do I minimize the impact on my life of this cancer so I can live a long time, a happy life, and do what matters to me in that life.
Whew. Dr. Hope dropping medical and philosophical gems on us today. That was a great response. I really appreciate what you said. And you can't see this, Dr. Hope, but on my end, you know, there's these little emojis that people can send when they're, you know, feeling the love, and they're all flooding in right now. So it resonated with the people out there too. I think that's such an interesting and profound point that you made. Thank you for that. Let's get back to some imaging talk. From Tiftom, I hope I'm pronouncing that correctly. Can you speak more about the specific PET tracers outside of the Gallium-68, like F-DOPA or 11C 5-HTP? I'm unaware of that. No, I know of a case where residual disease suspected in the ileum on MRE, but gallium was negative. Could tumors have weak receptors?
Okay, so there's a lot of questions packaged in there indirectly.
That's all I'll say. Did you follow that?
So yes, there are neuroendocrine tumors that have low uptake on somatostatin and receptor. Absolutely.
Okay.
Now, we generally think about the story of high Ki-67, poorly differentiated, losing its expression of the somatostatin receptor and thinking of it as indicating higher grade tumor. So when we see a net with low expression, in the back of our minds, we're always thinking, oh goodness, that could be a bad acting tumor. But there are well-differentiated G1 nets for whatever reason that have low expression of the somatostatin receptor. It's not common, right? It's very, very uncommon, but it is possible. So there's always these outliers with low Ki-67 tumors that have low expression. So that is a real thing. Now, they commented on, I think there was an F-DOPA statement. F-DOPA, there are certain neuroendocrine tumors that are better visualized with F-DOPA. Now, one of them would be things like paraganglioma pheochromocytoma, which are actually seen very well with dotatate, but also do have very good uptake on F-DOPA. But also insulinoma, for example, is an example of a neuroendocrine tumor which can be imaged well with F-DOPA. Now, F-DOPA is a little bit of a problem because very few sites, particularly in the US, have F-DOPA available. This is something done primarily at the NIH in the United States, so we don't do F-DOPA. We have an IND for F-DOPA with congenital hyperinsulinemia, which is a very rare disease. But anyway, separately it's not something that you could consider getting access to. I'm also not familiar with C11, whatever that compound is. The one comment I'll make about C11 has a 20-minute half-life. It has to be made in-house. In essence, for you as an individual patient, it's not going to be something that can be marketable or made by a company and taken to the market. So it's unlikely ever to see the light of day. F-DOPA is actually, oddly enough, FDA approved. Who would have guessed? But it's FDA approved to image patients for Parkinson's disease, not for neuroendocrine tumors. I'm hoping someday people will amend that NDA to include it for neuroendocrine tumors, because there is definitely a role for F-DOPA, but it's not yet used in the United States at really any site other than the NIH, where they use it primarily in paraganglioma pheochromocytoma patients.
Got it. Thank you. Suzanne says, I am newly diagnosed and just wanted to say thanks for these lunch chats. I've learned a lot. Suzanne, you are very welcome. We appreciate you being here. That is what we're here to do. Dr. Hope Diane says, could you explain the difference between copper-64 and gallium-68 scans? I don't think we've talked too much about copper-64 today.
Yeah, so copper-64. So copper-64 and gallium-68 dotatate, they use the same ligand. They're both dotatate. They both bind to the same receptor using the same molecule. All that's different is the radiometal that's attached to it, obviously the gallium or the copper. Both emit a positron, okay? Now, the way a PET scan works is the positron gets emitted from the copper, the gallium, then that decays and gives off 2 photons. You detect it with the PET scanner, et cetera. So what you'll want is a bunch of positrons. Now, there's 2 main differences between these. So one is half-life, okay? So gallium-68 has a 68-minute half-life. That's pretty easy to remember. Copper-64 has a 12-hour half-life. So much longer half-life with copper than with gallium. So that's point number 1. Point number 2 is copper has a lower positron fraction. What does that mean? So that means if I give 5 millicuries, fewer percentages of the decays results in a positron being emitted. Okay. Now with gallium, it's I think 89%, 88 point something, 89% of the decays give out a positron, which means a high percentage of the decays from gallium result in a positron that can be imaged. With copper, I think it's 17%, so it's much lower. Okay, so you have fewer positrons. So what that means is that with the same administered dose, and they're given around the same activity, there's less positrons that give off fewer photons to be imaged. Now, copper has a longer half-life. So when you image 1 hour out, you actually have half the amount of gallium, right? Because of the decay, because it's 68 minutes. Copper hasn't really decayed anything at that time. So you have, the gallium goes from 89 to 48 or 45%, and the copper is at 17%. I'm making up numbers here. So there's still more positrons with gallium than with copper, about 2-fold at the time of imaging. Mm-hmm. So copper is going to be a little noisier. Okay, so with older generations PET CTs, copper can cause a problem, and so the people who developed copper, the company, has created protocols for some of these older generation PET CTs. But at the same time, it's interesting. There's actually a third fact about copper versus gallium. The positron travels a shorter distance from copper. It only travels about 1 millimeter to 1.5 millimeters, whereas the positron travels about 1 centimeter with gallium. So it goes much further with gallium, so there's more blurring with gallium. You can sort of already start to see a lot of stuff is going on, right? It's not exactly clear. And in the end, when they've done head-to-head of gallium dotatate versus copper-64 dotatate, Now, the reports have shown higher lesion detection with copper. Overall, I think when using the right technique, I think of them as the same. So I think what's most important is, so at our center, it actually took us, I'd say, a couple of weeks to be like, whoa, this looks a little noisy. And particularly on our older generation PET-CT, which has now been taken offline. So that's no longer a problem. That was an issue. So we actually converted them all over to different scanners to make sure that wasn't a problem. But as long as you're using a good technique, there's absolutely no difference. And you can make them equivalent also even on older non-generation, non-time-of-flight PET-CTs. So that might be a little too detailed of an answer, but I consider them equivalent. And in the end, what's happening is a lot of people who have moved over to using copper, not because of the fact one is better than the other, but for two other reasons. Copper, with its 12-hour half-life, can be made centrally in large amounts and distributed, right? So you can make 100 doses centrally in the US and distribute them around the country. Gallium, you have to have a generator. You can make 1 dose per elution, and you can do 3 elutions a day. So if there's a generator and you live in a city and it's being distributed from Cardinal or some company, they can only make 3 doses. And so it's much harder to schedule, right? Because you have to have your PET-CT scanner open and available at the time when the dose is available. And so it becomes actually very hard to schedule. So that's the first thing, is the much more easily distributed copper. And then the other thing is this weird rule. And so if any of you want to get involved in patient advocacy and lobbying, this is a weird rule that you might want to focus on. Medicare does not reimburse for the radiopharmaceutical after 3 years. This is called pass-through. And so we no longer get paid for Gallium-68 dotatate because it's off pass-through from the Medicare perspective. So if you have Medicare, we have to cover the cost of that drug, which is more expensive than the entire imaging study. So we lose literally thousands of dollars doing a Gallium-68 dotatate patient in patients who have Medicare. I don't like to think that insurance makes a difference, but this weird rule, this federal law, in essence, causes these shifts to happen. Again, I don't think there's a clinical difference, but that's one of the major reasons and why we moved, because we would literally lose 7 figures a year because we do so many Gallium-68 dotatates that obviously are, you make a decision, you immediately move to copper, especially if they're considered equivalent. And so maybe too detailed of an answer, but
a thorough answer. Folks, we got just shy of 20 minutes left. We're going to keep on going. Great questions today. Question from Wendy. What's out there for non-peptide receptor neuroendocrine patients that have already been Whippled? So that's PNETs, yes.
So non-peptide,
what's out there for non-peptide receptor patients?
What are other therapies in patients who've had a PNET after a Whipple?
Correct.
Okay. So the main thing to note after a Whipple, right, is that liver-directed therapy gets limited, right? Okay. You can't do a taste in someone who's had a Whipple because of very high risk of infections and, abscesses and things like that. So you're sort of stuck with other types, not stuck, but other treatments. You can do Y90 radioembolization. So depending on the types of tumors, sizes of tumors, those are options to you. And then if you remember early on, I gave a long description about how I think of PRRT versus other therapies. And I mentioned capecitabine temozolomide being a very effective therapy for patients with pancreatic neuroendocrine tumors. And so that's definitely a therapeutic option there. There's obviously clinical trials. So one of the ones that we would love people to enroll in is called cabozantinib, or the CABINET trial. It's a phase 3 study of cabozantinib versus placebo. And so in that setting, using, enrolling in trials like that would also be very helpful. There's also 2 other FDA-approved drugs, everolimus and sunitinib, which are used in patients with pancreatic neuroendocrine tumors. And soon there'll be, I think, some other interesting trials for patients opening as well. And then obviously PRT, but I'm assuming the question was, what are non-PRT approaches to treating patients like that? PRT is safe, obviously, post-Whipple.
Got it. Well, this is a good question that kind of piggybacks onto that answer from Jim. Is there any advancement in radiation options for patients who do not have receptors? So they're not candidates for PRRT. This might have been what Wendy was asking too, who are not candidates for PRRT or Y90 treatment. Multiple lesions throughout the liver and management with lanreotide injections and surgery have been the only options to date.
Yeah. So PRRT is in essence the standard radiation therapy for patients, not available to patients who don't express a somatostatin receptor. So if you're somatostatin receptor negative, you're not going to get PRRT. Now we always think, as the question asked, well then those are the patients you give Y90 radioembolization to, right? So if Y90 radioembolization is not an option for whatever reason, I don't know why that would be the case in this setting, but then there's not a lot of other options. You can do external beam SBRT radiation therapy, so standard radiation oncology therapies, if you have localized, so if there's one big lesion or periportal disease, just a node that you want to hit, you can target that. But it's not systemic, and it can't be used to treat systemic disease. So it really depends on the anatomy. And external beam does work pretty well. So that can be used. And this is again where a tumor board discussion with everyone, and we do have radiation oncologists who attend our tumor board for this reason, because there's use of external beam radiation therapy. Now, there are potentially other PRRT type of therapies, not PRRT lutetium dotatate targeting somatostatin receptor, but there are other receptors you can consider. They're not really very far along, and I don't see yet something that I would say, hey, this is a great option, but there are studies in Europe using something called UPAR, which is another marker like the somatostatin receptor. Usually that's thought of in more aggressive, like poorly differentiated G3s. Maybe someone like that would be a candidate for that. And that's in more phase 1 trials just starting. So there's other things that people could consider. With paraphia, you can think about MIBG, right? I-131 labeled MIBG. But for a PNET, there is, other than SBRT, there's not much outside of PRRT and Y90 radioembolization.
And just so I understand correctly, you're saying that if patient does not have receptors, that doesn't mean they're not a candidate for Y90.
It's actually the opposite. Yeah. So
Okay.
if they don't have receptors, they should be considered a candidate for Y90. So we generally don't use Y90 radioembolization in patients who have good somatostatin receptor expression because we want to preserve liver function for PRRT. Y90 actually can cause pretty significant liver toxicities, and people are starting to become more aware of this. There's, again, everything is about style and everyone has different styles. My general feeling is I'm hesitant to use Y90 in patients with neuroendocrine tumor because it does have a pretty real risk of long-term liver toxicity. Now and there's a nuance to that. If you have localized disease in the liver, a big lesion on one side, and you can get a catheter out to it and treat it with Y90 and not irradiate the rest of the liver, it's a great therapy, no matter what. Okay, so that's a very good way to use it. But a lot of Y90 is done low bar, where you just inject it to the entire liver. And when you give low bar Y90, you cause injury to the background normal liver parenchyma, and it can cause radiation-induced liver disease. And if you have hepatocellular carcinoma with a big lesion and your lifespan expectancy is like 12 months, okay, this is not an issue. But when you're talking about a neuroendocrine tumor patient who might live 10 years and you hurt someone's liver, you're getting yourself into trouble. So you just want to be very careful with Y90. And that's why in that setting, we don't use Y90 in patients who have somatostatin receptor expression. It is a very effective treatment. Remember how I said that PRRT only shrinks 13% of disease? Y90, it's like 70%. It kills tumor very well. It's a very effective therapy, but you can't treat all the tumor. So it's not curative, and stuff will come back faster, oddly enough. Even though it's more effective, sort of similar to the PNET discussion, you can't treat all tumor frequently with Y90. So I like Y90 even if it's somatostatin receptor positive. If you have localized bulky disease that can be treated with a targeted therapy, or in somatostatin receptor negative patients where PRRT is not an option.
Got it. Thank you, Dr. Hope. I just want to share a couple of things with you. This, the comment section I see is like a little bit behind, our chat. There's a little bit of a lag. So I'm seeing a lot of comments during the comment that you made about just your approach and perspective on cancer, on the word cancer and curing cancer and all that. And a lot of that really resonated with a lot of people. I had mentioned that earlier when I saw the hearts flooding on the screen, but a lot of people were saying, thanks for the reality check. That's my approach too, to, live in the moment and just try to reduce stress. And one guest specifically said, brilliant guest. referring to you. So I just wanted to make sure that you heard that. And Skip, I agree. That's why we had him on the show. Folks, about 10 minutes left. We're going to keep moving forward and getting to as many of these questions as you can. But just to reiterate, if we don't get to them, you can follow it with CCF either here on the Facebook page. You can send them a private message. You can also visit their website, carcinoid.org, and they will try to get you that information. Or the simplest way too is just to show up next week and get your question across. We are here every week. And of course, you can replay the show as well. From Terry and a few other people, what is your opinion on continuing monthly octreotide if blood sugars and A1C are climbing? Last A1C was 6.6, and I've been on injections for over a year.
Okay, I'm gonna pass on that. In all honesty, I'm not familiar with somatostatin analogs being an issue in sort of a pre-diabetic patient. And this is where, ask that to a medical oncologist who manages that dosing, because I'm certainly not the right person to answer that question. I don't want to give some inappropriate comment.
Understood. Absolutely. Okay. Excuse me. From Monica, is there any data collected to show long-term effects of octreotide shots?
So to me, what's the main toxicity of octreotide? Financial. It's expensive, right? There was a generic version of I think it was lanreotide approved a couple weeks ago, and I'm sure the price won't come down. But I think financial toxicity is the main toxicity of SSAs. The second one is it's a pain in the butt. Literally, it's a pain in the butt. It hurts. A lot of patients have a lot of pain from the injections, and that can be troublesome for patients over time. And then the third major long-term toxicity is going to be cholecystitis, gallbladder injury, right? So this is why, when you do have your definitive surgery to take out your pancreas or your primary tumor in the small bowel, you want to have your gallbladder taken out as well. But in patients beyond that, I'm not aware of any other long-term toxicities other than pain, financial, and gallbladder injury. But again, I'm not the person who manages that so much, but those are my quick thoughts on it.
Got it. Thank you. From Bernadette, who has asked a question earlier, she says, being NED for 12 years, is it okay to be rescanned in 5 years? Is that ideal? Is that safe?
So, okay, first of all, being NED for 10 years is phenomenal.
Right.
I love it. Great. Good job. Secondly, there's a lot more details. One would want to know what type of primary tumor it was, how big was it, were there positive lymph nodes, et cetera, et cetera. So, this is where you want to talk to your local surgeon, medical oncologist. Generally, NCCN guidelines don't make recommendations beyond 10 years. Something like 90 to 95% of patients who are NED with NET will recur within that time period. So we don't have much data on what happens after 10 years. So I would not say 1, 10, 2. There's no right answer here. But I would recommend talking with your physician, understanding, what was a Ki-67, what's the risk of recurrence, and, make a decision there. But, I would be very happy with where I'm at in your case, and not worry too much about the imaging.
Got it. This is a question from Peggy that often comes up when we're talking about PRRT. What treatment do you recommend after progression begins after the PRRT cycles? Okay.
So there's, going back to my original long diatribe on primary tumors, what are the available options? It really depends, right? So again, it's a mixture of, the orals of sunitinib, everolimus, sunitinib only in pancreas, Cape-Tem. Sometimes people use FOLFOX in small bowels, standard IV chemotherapy. You can consider repeat PRRT. That depends. I consider repeat PRRT depending on A, uptake, B, how well did the patient benefit from the first one, and then 3, how well did they tolerate it, right? Was there toxicities that were dose limiting, et cetera? How long was it since they've had it? So I think the repeat PRRT is an option that one can consider as well. Then you have liver-directed therapy, depending on where your tumor is, et cetera, external beam radiation. It's the same discussion as we had before. I think the only caveat is how do we consider repeat PRRT and when should that be used in patients who've been previously treated with PRRT? There is potentially an issue that not all insurances will cover repeat PRRT, but we've been able to successfully do that in the handful of patients we've started seeing come back. Dotatate was approved in 2018. We're just about 4 years out. So we're just seeing the patients who benefited from PRRT start to come back, right? And so we're just starting to retreat some of those patients with repeat PRRT. And there should be a trial open soon of repeat PRRT in neuroendocrine tumor patients to hopefully get that added to the label, because that will be an important thing.
Yeah, absolutely. From Cindy, what are your thoughts on the new alpha PRRT that's coming but not here yet?
Yeah, I'm very excited. I mean, the data published with lead-212 dotatate is appealing. It definitely showed very impressive response rates. And I think we all really want to see it get into a phase 3 trial that can lead to approval. I think this is, it so far has been available only at one site, which is a little odd. But hopefully a company will partner and help develop that drug and bring it into a phase 3 setting to really evaluate and understand it. But there's a paper just published in the Journal of Nuclear Medicine of the phase 1 results, and the lead-212 data looks really very interesting. And hopefully there'll be other alpha emitters. Lead's a funny one. It has a 6-hour half-life. And so you can't ship it. So the way lutetium dotatate works is it's made in Jersey. It has a 7-day half-life. You ship it out around the country. It gets, 48 hours to be used. Very easy to distribute. Lead with a 6-hour half-life has to be made regionally, locally. So you have to have all of these manufacturing facilities around the country. So it's going to be a little bit of an issue to make it available to all patients, right? Rather than just a single center making an offering. But I'm very hopeful. There's presumably money to make here. And, so hopefully a company will get into this and really set up a structure where it can be studied and evaluated. And then obviously there's other alpha emitters coming down the pike. Obviously, primarily the one that we are hoping to see in a trial soon is actinium-225.
Got it. Folks, we have time for maybe 1 or 2 more questions. Jennifer and a few other people are interested in this question. Jennifer says, I have a neuroendocrine tumor in the small intestines. It has moved to the lymph nodes. Doctor said no need to take it out because it has moved to the lymph nodes. Should I seek a second opinion? Also, I have carcinoid syndrome. I'm taking lanreotide, but it's causing horrible knots to form.
Yeah. So I obviously don't know the case well enough to say, yes, this person should get a second opinion or not. And I don't know who their clinician is, et cetera. So as a general statement, I think everyone should get a second opinion. And my reasoning for that statement is a little odd. So not because I think the second opinion will change your management, right? I don't think the second opinion, it's infrequent that the second opinion will disagree with whomever your treating physician is. But I think it does give you a lot of peace of mind as a patient that you're making the right decision, right? If you've gone out and you've talked to someone else and that person agrees with the first person, then you're confident, you're not doubting it, right? And you feel, I think it's important as a patient to have not worried that you did the right thing or not. And I think a second opinion, if I were a patient, I would get one, whether or not I agreed or disagreed with my physician who's treating me, but just because I would want to know that I feel comfortable doing whatever it is, the path that they've chosen for me. So I think second opinions are very, very valuable. And the nice thing in our Zoom world we live in, very easy to do. You don't even need to travel. Right. They can send the images over the internet. All of the notes can be sent virtually. You don't have to physically go there, and they can review your chart, give you a very insightful, I agree, I don't agree, here are the things you should think about discussion. And I think that's incredibly valuable from a patient perspective. And I would do that independent of the specific circumstances that are being described.
Got it. Thank you. Rebecca says, hi, joining late, not feeling good today. We'll watch the full episode later. Thanks, Rebecca. Appreciate you being here. She is one of our regulars. But just to let you know, Rebecca, when you watch it later, you're in for a treat because, as Jem says, fantastic level of detail in the answers today. Amazing and so appreciated. And Anne-Marie co-signs that with, I truly wish all doctors could answer questions like this man. Amazing. That's you, Dr. Hope. That's you they're talking about. Let's see. One from Suzanne. I had a grade 2 tumor found after an appendectomy in 2004, and then I was told I was clear. That tends to happen a lot. Guess we've learned a lot about NETs since then. Indeed. Now, 18 years later, I finally realized I've had carcinoid syndrome the past 2 years. Is 16 to 18 years longer than average for recurrence, or perhaps I've had tumors much longer than that?
So 16, 18 years is very long. And, I don't see a lot of appendiceal carcinoids, right?
Okay.
Because they generally don't metastasize. And as I mentioned earlier, appendiceals are the ones where sometimes you cut them out and you never see it again. So I don't have a ton of experience with appendiceals, but I would set aside the history of the appendiceal carcinoid and assume that's unrelated to whatever's going on now. What I mean by that is whatever's going on now is either carcinoid syndrome caused by a new tumor or symptoms that are mimicking carcinoid syndrome. Does that make sense? So there's a lot of patients who have what feel like carcinoid syndrome that's actually not caused by cancer, and we don't really know what causes it. And this is where, remember I was talking about when you're looking for an unknown primary. Sometimes that's because you have biochemical evidence or symptomatic evidence of a carcinoid. Getting a dotatate PET just removes that question off the table. If it's negative, you're done, right? And then you can move on and deal with the symptoms. And it's not something you're going to treat oncologically, surgically, with PRRT or anything like that. Not, so then you have to be worried about symptom control, but you're not worried that you have cancer.
Got it. Karen says, we have so much more hope now, thanks to Dr. Hope. But then she also chimes in and says, thank you to Rain for hosting. We love you as well. I just had to throw that part in there. Dr. Hope, I think last time we talked, we were not limited. I don't like to use that word, but we were focused specifically on one topic, right? And so today I'm really appreciative for you being here on this episode, because I think that since we opened it up, I mean, your questions are extremely informative. Obviously, the comments show that too, but I really have appreciated, and I think they have as well, like your perspective. And I made the joke earlier about, philosophy, but it is a philosophy. I think that's just as valuable. So I appreciate you kind of sharing that part of your knowledge and experience as well too. And just thank you so much for being here.
Yeah, I think this is a great thing that you do, Rain. And hopefully the point I get across is I'm not right all the time. None of us physicians are right. And I think what's really great about this, and why I'm more than happy to always participate in these, is the more patients hear from various voices and various opinions, you get a feeling as to what's going on, right? And, I'm sure I've disagreed in what I said with other people before me on this show, but I think it's important for you to hear these various opinions, because in the net field, why it's so great is it's heterogeneous, variable, patient-specific, and there's no right answers because of that. It's impossible to give it's always true statement about anything in neuroendocrine tumors. And this is why I love it, because, you come in and every time I learn something new from an individual patient or a way we manage something, because it's completely different every time. And I think these sessions that you put together, and obviously there's many of these going on all the time, are incredibly valuable for patients so that they can really hear the variety of what's going on.
Such a fine point. I mean, somebody had said 3 different doctors, 3 different opinions, and I know that can be frustrating for people, but that's a total fair point. And also understanding that each path for each person is different, and their priorities are as well. So I appreciate you being here, and folks, I appreciate you as always for being here too. You say a lot of sweet things to me. I'm the host of the show, so kind of the face of it. But it means so much to me, sincerely, to be a part of this community, be welcomed into it. But I also always have to give all credit and respect to Carcinoid Cancer Foundation for having this idea and putting this program together. I am the vehicle that helps put it out to the world, but it was all their idea and their program. So thanks to them. Thanks to you as always for being here. And we hope this program helped to answer some of your questions. And I saw a few people who joined late and they missed it. Well, just know that this video will live here under the videos tab on the Facebook page starting Monday. It will be on YouTube as well. So you can definitely rewatch the program as well as all of our Luncheon with the Experts and all our videos you can access. We have a whole database, a whole library. Thanks again to our presenting sponsor, Ipsen Biopharmaceuticals. Without them, we couldn't do this program. And finally, my name is Rain Bennett. I have been your host. Thank you for watching, and please join us next time on Luncheon with the Experts. Stay healthy, stay safe, everybody. Bye-bye.
Thank you.